to a case discussion on uterine prolapse from diagnosis to definitive management. I would like to welcome Dr. Veerabhadraya T.A. Sir, President, IMA Karnataka State Branch, Dr. Surraju V. Sir, Honorary Secretary, IMA Karnataka State Branch, Dr. Jaspal Singh Tehelia Sir, Chairman, IMA MSN Karnataka State Branch, and Dr. Avin Alva Sir, Co-Coordinator, IMA MSN Karnataka State Branch, and our moderator for the day, Dr. Bhavya H.U. Ma'am, Professor and Unit Head, Department of OBG, Subbaya Institute of Medical Sciences, Shimoga. Welcome to the session, ma'am. And presenter for the day, Ms. Sara Purushottam, final year MBBS student, AJ Institute of Medical Sciences. Now I would request Apollomi to take ahead. Thank you, sir.
Good evening, everyone. I'm Paulimi, a final year medical student from AJ Institute of Medical Sciences. On behalf of IMA, I would like to welcome all the dignitaries, faculty members, medical students, and attendees present here today. So we'll get started with the session. To begin the program, I would request Ritika to start with the flag salutation.
We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it, and realizing our responsibilities as the accredited members of this national organization, we swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind, long live IMA.
Once again, prayer needs to be done first, then flag salutation. You're not done prayer. I am a prayer. Srinidhi.
Yes, sir. Sorry for the inconvenience. Shreya, are you in the meeting?
Yes, Srinidhi.
Can you please proceed with IMA prayer?
Yeah. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Thank you.
Thank you, Shreya. It is now my privilege to introduce our presenter for today's session. Our speaker, Ms. Sara Purushottam, is a final year MBBS student from AJ Institute of Medical Sciences Research Center. She has shown keen academic interest in the field of obstetrics and gynecology and will be presenting today's case on uterine prolapse, from diagnosis to definitive management. We are pleased to have her here with us and look forward to an insightful presentation. A very warm welcome to you, Sara.
Thanks, Paulini.
It is equally my honor to introduce our moderator for today's session, Dr. Bhavya. Dr. Bhavya is a professor and unit head of the Department of Obstetrics and Gynecology in Subbaya Institute of Medical Sciences, Shimoga. Her impressive professional credentials include MBBS, MS, and DMB qualifications, fellowship in cosmetic gynecology, over 14 years of experience, Best Paper Presentation Award at Kasoga 2024, Prize winner in Consultant Quiz at Kasoga 2025. She has special interest in cosmetic gynecology and laparoscopic surgery. She has multiple publications in national and international journals. We are grateful to have such an accomplished academician and a clinician moderating today's session. A very warm welcome to you, ma'am.
Thank you, Paulimi.
Without further delay, I would like to invite Ms. Sara to begin her presentation. Over to you, Sara.
Yes, sir. Now it's visible. You can go ahead.
Good evening, everyone. My name is Sarah Purushottam. I'm a final year MBBS student from AJ Institute of Medical Sciences and Research Center. I'll be presenting a case on uterovaginal prolapse today. So, a 44-year-old female, Mrs. Pushpavati, hailing from Kadri, Mangalore, who has studied till SSLC and is a homemaker by occupation, was admitted on 24th of February 2026 and examined on 25th of February 2026. Her LMP was 6th of February 2026. Patient came with complaints of mass coming out of her vagina since 1 year, difficulty in passing urine since 4 days, urinary incontinence since 4 days. History of present illness. Patient was apparently normal 1 year back, following which she noticed a mass per vagina. Initially, the mass appeared during straining and prolonged standing and reduced on lying down. Gradually, it increased in size, became manually reducible, and started interfering with day-to-day activities. For the past 4 days, patient has been complaining of difficulty in passing urine, incomplete bladder emptying, and occasional urinary leakage. There was no history of abnormal vaginal bleeding, no history of pain abdomen, no history of foul-smelling vaginal discharge, no history of pruritus, no history of bowel disturbances, no history of fever or weight loss.
Okay, Sarah. Yeah. So we'll just have a discussion with this presenting complaints and history of presenting illness.
Yes, ma'am.
So this patient has come with a mass per vagina since 1 year, right?
Yes, ma'am.
So can you tell, once the patient tells you that there is a mass per vagina since 1 year, what were the differential diagnosis you
Yes.
will keep in mind in a history wise?
Ma'am, when the patient says 1 year, firstly, I would think of prolapse of uterus. Then I would also think of
Yes.
enterocele, cystocele, and retrocele, ma'am. These would be the most common ones I would keep in mind. Other than that, there can also be cervical. That can also be one of the causes, ma'am. Then other than that,
See, she is a 44-year-old, right? She is in the reproductive age group. Okay. So in a 44-year-old with mass per vagina, okay, first, according to her history, you can keep uterovaginal prolapse. But there are
yes,
certain other conditions also which you should keep in mind, especially when the patient is in this reproductive age group. Yes, can you tell? Like your fibroid polyp, right?
yes, ma'am.
Fibroid polyp can be there, or as you told, cervical, like congenital elongation of the cervix.
Yes, ma'am.
Okay, so that can be there. Okay, so most likely to be these are the few, and or the that sometimes it can be chronic uterine inversion also,
Oh,
right?
yes, ma'am.
Okay, so at least whenever the chief complaint, whatever the complaint the patient tells you, you should have few your differential diagnosis in your mind, so that in your negative
Oh,
history you are going to rule out all these conditions, right?
yes,
And along with that, she has one more complaint is urinary complaints, right? She
yes,
has difficulty in passing urine.
yes,
So
ma'am.
why there is difficulty in passing urine? With
Ma'am,
what condition you think it will be?
ma'am, since there's a mass in the vagina, and since it's due to the descent of the uterus, it presses on
Yes.
the urinary bladder, so that can cause urinary incontinence.
Incontinence. Okay. Urinary incontinence is due to what here? So you should keep in mind that anterior vaginal wall prolapse. So
Yes.
the relation of bladder and also the urethra, right?
Yes.
So it is the upper 2/3 will be the bladder, that is cystocele, and the lower 1/3 will be your urethra. Okay.
Yes.
Incontinence is usually if it involves the urethral descent also, or the urethrocoele, what we call, right? Most of the time, if there is a associated urethrocoele also, they will have incontinence. Difficulty in passing urine. Why there is difficulty in passing urine? Because there is the bladder is descended down. So
Yes,
it will alter the vesico-urethral angle,
yes,
right?
ma'am.
Okay, so the most of the urine will get collected within the bladder, in the descended part.
Yes, ma'am.
Okay, and there can be obstruction of that angle, vesico-urethral angle. So there will be difficulty in passing urine once the mass is outside.
Yes,
Okay, it will be an obstructive cause.
yes, ma'am.
Okay, it will lead to obstruction. And you have also written that there is an incomplete bladder emptying,
Yes,
right?
ma'am.
What does it mean? Incomplete bladder emptying.
Ma'am, after urination, some part, like some urine is still present in the bladder, which leads to dripping of urine. Like after,
Incomplete means once she passes urine, again she feels like passing urine, means
yes,
increased frequency. So
yes,
she will have that sensation to pass urine again. So
yes,
that is incomplete emptying of the bladder because the urine is collected within the cystocele, right?
yes,
And urinary leakage. Once you have occasional urinary leakage, you have written. So there is an occasional urinary leakage means involuntary urinary leakage.
yes,
Is it an
ma'am.
involuntary urinary leakage, right? So
Yeah.
involuntary urinary leakage can be either due to two types, right? Stress incontinence or urge incontinence. So
Yes,
here it should be elaborated a little bit. If the urinary leakage is there on coughing or doing strenuous activity, right?
yes,
Or is it because of urgency, right? Urgency to pass urine and there is a leakage of urine.
yes,
Okay, that needs to be clarified here. Okay, most of the time with the uterine prolapse, there can be both components, urge as well as stress incontinence. Okay,
yes,
yeah.
yes.
So just can you brief the negative history, why you have taken, what you want to rule out with all this?
Ma'am, I've written no history of abnormal vaginal bleeding. So usually abnormal vaginal bleeding is seen in malignancy and fibroids. It can rule out all that, and endometrial pathology can also be ruled out. No history of pain abdomen I've written, ma'am. That is usually seen in ovarian pathology, torsion, uh, and PID, ma'am, pelvic inflammatory disease. Then no history of foul smelling vaginal discharge. It's usually seen in candidiasis and cervical infections. Can also be seen in malignancies, ma'am. I've also then no history of pruritus because it can be seen in candidiasis again, vulvovaginitis and chronic, and if there's chronic irritation. No history of bowel disturbances I've written, ma'am. This is mainly if she has constipation, that can be ruled out. No history of fever or weight loss to rule out urinary tract infections or tuberculosis, ma'am.
Yeah. So no history of abnormal vaginal bleeding. Here, one of your DD is fibroid polyp, right? If there is a fibroid polyp, usually the patients will have abnormal uterine bleeding,
Yes,
right? Abnormal uterine bleeding in the form of either menorrhagia or intermenstrual bleeding. Okay.
yes, ma'am.
And pain abdomen with the prolapse. So your first differential
Yes, ma'am.
diagnosis is prolapse. The patient can have pain abdomen, right?
Yes, ma'am.
If she has urinary tract infection, right, associated with that urinary tract. Most UTI is common, right, in a patient with the prolapse because of the stasis of the urine. So it is urinary tract infections are very common. So the pain can be because of that. Okay, and foul smelling vaginal discharge. In a prolapse patient, can they present as a foul smelling vaginal discharge? Any complication
They
of the
can,
prolapse,
uh,
like in case of
secondary, it can lead to secondary bacterial infections, ma'am.
chronic cervicitis, because the cervix is exposed outside, right? So it
Yes.
can lead to chronic cervicitis. And also, have you heard of decubitus ulcer?
Yes, ma'am. In
Right?
decubitus
So the
ulcer.
long-standing prolapse, if there is a decubitus ulcer, so the patient can present with foul-smelling discharge,
Okay.
right?
Yes,
Okay.
ma'am.
And also pruritus as such, okay, you want to rule out the vaginal infections. Okay, that can also be kept, but yeah. So as sir has commented that it should be in the patient's own words. So incontinence and all you cannot write. It's not in the history. Pruritus also. What you can tell, itching, right?
Yes.
Itching in the perineal region or the vaginal itching. You can tell like that. And bowel disturbances. See, the prolapse, it said it can be the constipation can be an aggravating factor for prolapse, or due to prolapse, the patient can have constipation, right? If there is a rectocele,
Yes.
so the patient can have constipation.
Yes.
Okay. So for that, see, keep your mind, like whatever the differential diagnosis, you should keep in mind. Accordingly, your negative history should be. So what all I am ruling out? All this history, are they favoring towards your uterine prolapse, or are they favoring the fibroid polyp or other differential diagnosis? And no history of fever or weight loss to rule out malignancy, you told. In a 44-year-old lady, which malignancy do you suspect? Especially suppose if the patient has come with a mass per vagina and you are suspecting a malignancy, which malignancy would it be?
Uh,
Cervical cancer. Okay, in the
Okay.
40s, you see mostly with the cervical cancer. Cervical cancer can present with a mass, right? Growth in the cervix, which can present as a mass in the vagina, and they can have foul smelling discharge also,
Yes.
or abnormal uterine bleeding also, and other associated cancer symptoms can be there, right? So
Yes.
one of your DDs, that's why age is very important, right?
Yes.
See, still in the reproductive, all these you should keep in mind. Hmm?
Yes.
Fibroid polyp, cervical malignancy also, along with the uterine vaginal prolapse. Suppose if it was a straightforward postmenopausal women with the mass per vagina, so straight away it will point out to your prolapse.
Okay.
Okay.
Yes.
So can you just if we will finish it off here, what are the urinary symptoms the patient can have with the prolapse? You have mentioned few here: difficulty in passing urine, incomplete bladder emptying, and urinary leakage or the urinary incontinence. Okay.
Yes.
So here, what other symptoms, urinary symptoms, the patient can present with the uterovaginal prolapse?
Ma'am, the patient can feel that there's residual urine still left in the bladder. Then there can be urinary dribbling, dribbling of urine, ma'am. Then the patient can have a weak urinary stream.
Can there be a retention of urine?
There can be retention of
Yes.
urine.
The large fire prolapse, okay, precedentia. As I told you, it can cause obstruction to the urethra, and there can be retention of the urine also. And UTI symptoms, increased frequency, burning, micturition, all these also can be symptoms, urinary symptoms they can present with. Okay, yeah. You can continue with
Past
that.
history. Yes, past history. There was no history of similar complaints in the past. No history of type 2 diabetes, hypertension, asthma, malignancy, or tuberculosis. No prior surgeries. No thyroid disorder. No congenital or chromosomal anomalies diagnosed. No blood transfusions. No known drug allergies.
What in this congenital anomalies, or the you have put now, what is chromosomal anomalies diagnosed? Like
Yes.
what you want to rule out here? Why you have asked that particular condition, or routinely, is it a routine to ask all this?
Ma'am,
Is it related to your case?
in conditions like Marfan syndrome,
Yes.
and
Connective tissue disorders, right?
yes, ma'am. In those conditions, there can be some congenital abnormalities, which can lead to weakening of the structures of the uterus, leading to prolapse of the uterus, ma'am.
Prolapse, right? Okay. And also anomalies, if you want to tell, spina bifida. So
Yes.
some neurological abnormalities that can lead to a prolapse in a very young age, right?
Yes.
What do we call it as we address it as a nulliparous prolapse, right?
Yes.
Okay. Yeah.
Coming to menstrual history, age at menarche was 13 years. Cycles were previously regular for lasted for 28 to 30 days. Duration of flow was 3 to 4 days. She used 2 to 3 pads per day. No dysmenorrhea and no passage of clots. Marital and obstetric history. She has been married since 26 years. Uh, she had a non-consanguineous marriage. Husband's occupation, farmer. Parity index is P3L3. Her first child was a male who was 25 years old, was immunized. Second child was a female, 24 years, immunized. Third child was again a male, 23 years, 3 years old, immunized. All three deliveries were full-term normal vaginal deliveries at home. There were no antenatal, natal, or postnatal complications during the same.
Yeah. So when you take your obstetric history, especially in relation to this case,
Yes,
so what is important, very important in your obstetric history?
ma'am, the number of deliveries,
Yes.
And then if there were any antenatal, natal, or postnatal complications, ma'am, that can also play a major role in prolapse in the future.
In this patient, what you find here? One is multiparity. She has 3 kids. And what about the interpregnancy interval duration?
Yes, ma'am. It's 1 year old between
Yeah, it's
every
very
child.
short interpregnancy interval.
Yes, ma'am.
And one more point, all are home deliveries,
Yes, ma'am.
right? All are home deliveries. Okay. So if there are home deliveries, what are the points which favor the or which would have caused, which would have led to this condition?
Ma'am, first of all, home deliveries, there can be a lot of aseptic conditions, and other instruments could have been used during delivery for easy facilitation of delivery, ma'am. So, which can lead to a trauma to the structures of the uterus, supporting structures of the uterus or to the uterus itself, which does play a role in prolapse in the future, ma'am.
The past obstetric history is very important, that too, especially at home deliveries by at home, which is unmonitored, right? Which is not monitored by a trained person. Okay, so there can be chance of premature bearing down. Okay, so in this patient, because at 44 years she has developed prolapse, means the two most important causative factors or the etiology for a uterovaginal prolapse is, what are the two important factors? One is your, most commonly when we see the uterovaginal prolapse. In which age group we see the uterovaginal prolapse?
In increasing age group, ma'am, in older age group, it's
Menopausal, right? In a most menopausal women. So the cause is mainly because of
ma'am, loss of estrogen.
estrogen, hypoestrogenism, right? That is the most important cause. Okay, so the second most important factor is obstetric trauma. Okay,
Yes.
so the prolapse which you see in a premenopausal, that this patient is in a premenopausal age, 44-year-old. So it is mostly because of a obstetric trauma. Okay,
Yes.
and all the factors are favoring here. She is multiparous and reduced interpregnancy interval and all her home deliveries.
Yes.
With the home deliveries, the factors which contribute to her prolapse are premature bearing down. Okay, with the premature bearing down. You understand what is premature bearing down? It's
Yes.
before the full dilatation of the cervix if the patient starts bearing down. Okay, because there is no monitoring there, chances that they will start bearing down before full dilatation, which can lead to stretching of the ligaments and
Yes.
also injury to the your main support, that is endopelvic fascia.
Yes.
Okay, stretching of the ligaments, tear in the ligaments or the fascia. These
Yes.
are the things which contribute to that. Okay, and
Yes.
we don't know whether it was a prolonged labor, right? Okay,
Yes.
and any instrumental delivery also can lead to tear in the endopelvic fascia, and also it can cause nerve injuries also, right? Neuronal damage also. Okay, and also tear in the fascia as well as the muscular support and the ligaments.
Yes.
All these can happen during the process of delivery, right? Unassisted delivery, episiotomy is not given. So perineal tears, right? And those perineal tears, if they are not approximated well, that can also be a cause for or then a predisposing factor for uterovaginal prolapse.
Yes.
Okay, all these factors favors that to develop her prolapse.
Yes.
And also if you can see that the duration is less, and most important in the postnatal period, what you should ask is whether she had adequate rest, resumption of her daily activities,
Yes.
early resumption of the daily activities, right?
Yes.
Again will not allow the tissues to regain its come back to its normal, right?
Yes.
So that will also be a predisposing factor for prolapse.
Yes.
Okay, yeah. So obstetric history is very important. You need to ask in detail about this because all these are home deliveries. Patient may not be giving you that much information, but try to elicit. Okay.
Okay.
Next you can.
Coming to environmental history, family, personal, and environmental history. No significant family history. She consumed a mixed diet. She has normal appetite and adequate sleep. No substance abuse. She lives in a Pakka house with 5 members with adequate light and ventilation. Her socioeconomic status is middle class according to BG Prasad classification. Coming to general
Which
physical
substance
examination.
abuse you want to relate? Just this one. Which substance abuse can be a contributing factor to your
Ma'am,
prolapse?
Ma'am, tobacco chewing.
Yeah, smoking and tobacco chewing, because again that will alter the
And
collagen synthesis. Yes,
yes, ma'am. Yes, ma'am.
okay, yeah.
Coming to general physical examination. Patient is conscious, cooperative, and well-oriented to time, place, and person. She is moderately built and moderately nourished. Her vitals were recorded as pulse 72 beats per minute, blood pressure 110 by 70 millimeters of mercury, respiration 16 cycles per minute, temperature she was afebrile. There was no pallor, no icterus, no cyanosis, no clubbing, no edema, no lymphadenopathy. Coming to systemic examination of the abdomen. Inspection, abdomen was normal in shape. It wasn't distended. Umbilicus was centrally placed and inverted. Flanks were normal. Renal angles were normal. No sinus, scars, or dilated veins seen. Hernial orifices were normal. No visible peristalsis. Abdomen moves equally with respiration. No visible abdominal mass. Coming to palpation, abdomen was soft. No local rise of temperature. No tenderness. No guarding or rigidity. No palpable lump. No organomegaly. Renal angle was non-tender. Percussion, tympanic note heard, liver dullness present, no fluid thrill, no shifting dullness. In auscultation, bowel sounds were present, no venous hum, no arterial beat. Systemic examination, CVS, S1 and S2 heard, no murmurs. In respiratory system, bilateral air entry present, no added sounds. CNS, normal higher mental functions, no deficit. Coming to pelvic examination. Examination was done in dorsal lithotomy position under adequate light and aseptic precautions. Inspection, external genitalia normal. On straining, cervix along with uterus seen protruding outside the introitus. A prolapsed mass was reducible. No decubitus ulcer or bleeding present. Cough impulse was positive. On speculum examination, cervix looked healthy. There was no erosion or ulceration. No abnormal discharge. On vaginal examination, uterus was normal in size. Cervix descends beyond introitus on straining, suggestive of third-degree uterovaginal prolapse. Anterior vaginal wall bulge was present, suggestive of cystocele. Posterior vaginal wall bulge was present, suggestive of rectocele. Fornices were free and non-tender. Per rectal examination, rectal mucosa was normal and there was no tenderness.
Okay. So coming to the pelvic examination, okay,
Summary.
just put the examination findings. Okay. So external genitalia is normal, means normal for that age. What you see when as soon as you do a local examination, right? Inspect, you will be seeing a mass, right? Outside, lying outside. So cervix along with the uterus. So means you are telling that cervix along with the uterus is coming protruding out. On inspection only, how you can tell it is uterus only which is coming out. Okay. So how you have to describe the mass, size of the mass. Suppose say 3 into 3 centimeter or 4 into 5 centimeter mass seen protruding outside the vagina. Okay, with you can see a opening that will guide you that it is a cervix, right? With the external loss, you will be able to, you can tell that external loss is seen outside. Okay, that is a cervix. Okay, and the mass, what is the color of the mass? Size, any mass, how to describe a mass? Size of the mass, right? Shape of the mass or the site, whatever it is. Okay, and any ulcers or any whatever you see that you have written, ulcer or bleeding or discharge. Okay.
Yes, ma'am.
Yeah. So the cough impulse is positive here. And one more thing, before doing this examination, because the patient had urinary leakage also, so you are supposed to examine for incontinence. Okay. Stress urinary incontinence. And when you are doing for a stress urinary incontinence, you have to do with the full bladder. Before asking the patient to empty the bladder, you have to elicit for stress urinary incontinence. And for eliciting the stress incontinence, you have to reduce the prolapse. If there is a prolapse, sometimes the prolapse can mask the stress incontinence, which is already there for the patient. Okay, because of the prolapse, sometimes it will be masked. So always, whenever a patient with the prolapse is there, you have to elicit, even though if the patient doesn't complain you of leakage of urine, involuntary leakage of urine, you have to elicit for stress incontinence. You have to reduce the mass, ask the patient to cough and see if there is a dribbling of the urine. Okay, if that is there, then stress incontinence is there. Okay, so before starting this, because the patient also complains of urinary leakage, you have to elicit, demonstrate for stress incontinence. Then you go ahead with we ask the patient to pass urine and come and examine for all this. Okay, yeah. So rest all is fine. And per vaginal exam, it is always a bimanual examination. Okay. Don't just write it as a per vaginal. It is bimanual examination because you are using both the hands, abdominal hand as well as the vaginal hand. Right? Okay. And all this, your cystocele, rectocele, should come in your perspiculum examination. Bimanual examination to know the size of the uterus, position of the uterus, whether anteverted, retroverted, and also mobility of the uterus or any tenderness like that. Okay. Yeah. So how do you tell that it is a cystocele? There is a bulge on the anterior wall. Yeah.
So when the anterior vaginal wall, if we can see a bulge, then it's suggestive of cystocele. And if we can see a posterior vaginal wall bulge, then it is suggestive of rectocele.
Okay. There is a condition called Gartner's duct cyst, right? It's a remnant of your Wolffian duct. So that can be a formation of the cyst there. That can also present as an anterior vaginal wall mass. How to differentiate the Gartner's duct cyst
Yes,
from
ma'am.
your cystocele? That is not prolapse, right? Gartner's duct cyst is not a prolapse. It is just a
Ma'am, cystocele is more commonly seen in multiparous women, postmenopausal women, whereas Gardner cyst can be seen in any age group, ma'am.
examination. You are examining now, right? You see the bulge in the anterior vaginal wall. So how
Yes,
to
ma'am.
tell whether it is a cystocele or a Gartner's duct cyst?
It's, ma'am, cystocele is soft and reducible.
Yeah. So cough
Whereas-
impulse will be positive. It is reducible, whereas the Gartner's duct cyst is not reducible. Okay. And if it is a
Yes, ma'am.
because of if it is a prolapse, what about to the vaginal rugosities?
I'm not sure.
Vaginal rugosities will be lost if it is a prolapse. Okay. Okay, here it is not. And if it is a cyst, you can easily make out all the borders of the
Yes.
cyst. Whereas here it is not a well-defined borders, right? Cystocele, you don't get well-defined borders to palpate that mass. And consistency also, that will be more of cystic, and here you cystocele, you feel it as a soft bulge. Okay?
Yes.
Yeah, fine. And per rectal examination, rectal mucosa is normal. Okay, fine. And why do we do, especially in a patient with a rectocele, you have told rectocele. Suppose the patient had an enterocele also. Okay,
Yes.
how to differentiate between these two, enterocele and the rectocele? By doing per rectal examination. You know that upper 1/3 is enterocele and the lower 2/3 is rectocele. Okay, sometimes there can be a confusion if it is a very large enterocele also. Okay, so how to differentiate that? When you do a per rectal examination, when you put your fingers in the per rectum and you bring it forwards, okay, towards the vaginal wall. If it is a rectocele, your fingers will be pushed towards that bulge. Okay. If it is an enterocele, you will not reach because enterocele is from the, where it is? Enterocele is due to
It's herniation of the pouch of Douglas.
small intestines, right? It is mainly the PO through the pouch of Douglas. It is the small intestines which will be coming. So your finger will not reach there if it is an enterocele. Whereas if it is a rectocele, your finger, you can easily indent on that mass. Okay. So that is one advantage of doing a per rectal examination in a prolapse patient. Okay. And few more examination is you have to elicit for the anal reflex also to see the neuronal, whether the nerve injury was there or not, because that is also one of the cause, right? Damage to the nerves. That can be done, and also levator tone assessment. Okay. So that can also be done to know the tone of the or the assess the muscles. Okay. Fine. Yeah.
Summary, a 44-year-old multiparous woman with 3 vaginal deliveries presented with mass per vaginum and urinary symptoms. Examination reveals 3rd-degree uterovaginal prolapse with cystocele and rectocele.
So according to what classification you are telling it as a 3rd degree?
According to Shaw's method.
Okay, can you tell stage 1, 2, 3 or the degrees of prolapse? What is first degree? What is second degree?
Yes, ma'am. In 1st-degree prolapse, cervix descends into vagina but remains above the introitius. In 2nd degree, cervix reaches the introitius. In third degree, cervix protrudes outside the introitus with part of the uterus outside. In procedentia, complete prolapse is there. Entire uterus is outside the vagina.
Yeah. So it is the cervix which is protruding outside is third degree, right? But the body of the uterus can be still within the vagina. Right? Yeah. Any other classification, for the prolapse, to grade the prolapse?
Yes, ma'am.
Yeah.
Yes, ma'am.
Can you tell about it?
Ma'am, POPQ. In stage 0, there is no descent. Pelvic organ descends but remains above the hymen. In stage 2, uterus reaches the hymen. In stage 3, uterus protrudes beyond the vaginal opening. In stage 4, there's complete eversion of the uterus outside the vaginal opening.
So the advantage of this POPQ is pelvic organ prolapse quantification system, right? Quantification means we are going to measure here. So it's an objective assessment. Okay. All the other grading, Shaw's classification or Baden-Würger, they all tells about it. Just by looking at it, you are going to tell, right? It is all subjective. Whereas this one is an objective because you are going to take all the measurements you are going to take, and it is a site specific. You are going to exactly see where exactly the defect is. Okay, site specific and objective. So you have to take the measurements here and then do. Okay, so we'll not go in detail with the POPQ scoring. So Shaw's classification is enough for undergraduate level. Okay, yeah. Next, have you put anything? Next.
So coming to the provisional diagnosis, it is third degree uterovaginal prolapse associated with stocele and rectocele. Differentials would be walled prolapse, enterocele, cervical elongation.
Walled prolapse will not come here because she doesn't have any history of previous surgeries, right? Suppose the patient gives you that there is a history of hysterectomy previously. She has undergone surgery. She tells you that the uterus was removed. Now she has come with mass per vagina. Then your walled prolapse will come. Okay. Cervical elongation can be there. Yes, one of your DDs. Now, we had few differentials, right? Fibroid polyp or cervical elongation or inversion. How to differentiate it from the prolapse? Suppose cervical elongation. How to differentiate it from a uterovaginal prolapse? What is the difference here?
In cervical elongation, the length of the cervix is increased by more than 5 to 6 centimeters. Then in uterovaginal prolapse, it's usually normal.
Okay, so one thing is vaginal part of the cervix has two parts, right? Supravaginal and the vaginal portion. So vaginal portion of the cervix is elongated in congenital elongation of the cervix. Fornices will be deep here. You will feel the deep fornices. Okay, vaginal convexity will be maintained. Whereas prolapse, what happens? Along with the uterus, there is a prolapse of the vaginal walls also. So shallow fornices. And here in prolapse also there can be elongation of the cervix, but the elongation is of the supravaginal portion of the cervix, not the vaginal part. Why supravaginal portion of the cervix elongates? Because the ligaments, especially the uterosacral and the Meccan rods, it will try to pull the uterus which is getting displaced or which is coming down. So it will lead to a traction on the cervix. So supravaginal elongation you will get in prolapse. Whereas if it is a congenital elongation, it is the vaginal portion of the cervix which is elongated. Okay. Prolapse, suppose if it is a fibroid polyp, how to differentiate?
Ma'am, fibroid, the polyp usually has a, how you can differentiate.
I think your voice is not that clear.
Ma'am, in a fibroid polyp, a pedicle will be seen, whereas in the uterus, uterovaginal prolapse, there's no pedicle seen. So that is one of the main methods how we can differentiate. Then other than that, it's usually uterovaginal is usually associated with cystocele and rectocele, while polyp it's not usually associated, ma'am.
Yes. Whenever you see the polyp, you see it as a broad mass. There is no opening to it, right? Cervix will be very high up. Whereas a prolapse, you see that the cervix which is coming out and there is a external loss you are going to see there. So that opening you will not be seeing it in case of a fibroid polyp.
Yes.
Or even in case of a chronic inversion also same thing, because the fundus will be outside. So there is no opening. So the cervix will be very high up in these two conditions. Okay.
Yes.
And other things like, as you told, vaginal prolapse will not be there if it is a polyp also. Okay. That's how by examination only you can differentiate. And prolapse you can diagnose clinically. You don't need any particular investigations to diagnose this condition. Okay, now this patient has come to you. So how do you want to further proceed with this patient now?
Ma'am, I would start with the investigations, and under investigations, I would do complete blood count, blood grouping, and RH typing, RBS and RFT, urine routine, USG abdomen and pelvis, ECG, chest X-ray, and pap smear.
Okay, fine. So why you want to do all this? Keeping what in mind that you want to do all these investigations to the patient? Is it going to be for a diagnostic purpose or for your management?
Ma'am, urine routine would be done to see if there are any pus cells or something like that to rule out
Infection.
infections.
Yes. Okay. Yeah. Because she has some urinary symptoms as well, right? Okay.
Yes, ma'am. Then pap smear should be done to rule out cervical cancer, ma'am.
Pathology. Yeah.
Then
USG
abdomen
ultrasound.
to basically see if there are any abnormalities in the uterus or to see where the position of the uterus also.
Position you will get to know by examination. See, the ultrasound will help you to know any associated other factor because she is 44-year-old. There can be associated other pathologies like fibroid, adenomyosis, or any adnexal mass. Ovarian cyst can be there, right? So you don't want to miss all those things. So for that purpose, you are going to do an ultrasound. And why do you need CBC, blood group, RBS, RFT? ECG, X-ray and all as a
to look CBC and all to look for
pre-operative.
Yes, ma'am. To look for infections.
So mainly all these for as a pre-operative workup, right?
Yes,
okay. Yeah.
Then coming to treatment, it's divided into two, which is conservative treatment and surgical treatment. Under conservative, pelvic floor exercises would be recommended. Then a vaginal pessary, which is a ring pessary, shown in the figure, can also be used. And then lifestyle modifications should be done. Under surgical, vaginal hysterectomy can be done. And pelvic floor repair, anterior colporography, posterior perineorrhaphy, bilateral salpingectomy if indicated.
Okay. So for prolapse, either you can have a conservative and a definitive treatment, right? Or even the obliterative procedures are also there. Considering her age and or 44-year-old. So depending upon the severity of the prolapse. you can go for this. In which patients would you like to prefer this pelvic floor exercises, also called as Kegel's exercises, conservative management?
Ma'am,
Is that
conservative. It's usually helpful for young females, ma'am, who have
with what degree of prolapse you want to tell this?
with first degree prolapse, ma'am.
Yeah, first degree prolapse. If it is a first degree prolapse, you can ask her to do all this lifestyle modification, avoid lifting heavy weight or pelvic floor exercises so as to prevent it further proceeding into second degree or third degree. Once if it is already a third degree prolapse, all these conservative measures will not help. Okay.
Yes.
And pessary is not a definitive treatment, right? So for a
Yes.
patient who is 44-year-old, you can offer her a definitive treatment. Okay.
Yes.
And your definitive treatment is what? And she has completed her family, right? She's
Yes.
para 3, living 3. So you can offer definitive treatment, that is hysterectomy, followed by pelvic floor repair. Okay.
Okay.
And salpingectomy, if indicated. Why you have written that if indicated?
Ma'am, there are some contraindications as well. So
It's a case in nowadays, whenever we do hysterectomy, it is a routine to remove the fallopian tubes.
okay.
Okay. So you're not leaving a fallopian tubes when you're doing hysterectomy, either abdominal or even with the vaginal also, we will try to remove the fallopian tubes.
Yes.
Okay. So leaving behind the fallopian tubes, again, as you know that it is again for a ovarian cancer or it can lead to hydrosalpinx, biosalpinx also. So better to remove the fallopian tubes along with that.
Yes,
Okay.
ma'am.
Yeah. So pessaries, when it comes to the ring pessaries, what are the indications to give this pessary treatment? Can you explain about pessary a little bit?
Ma'am, it's usually indicated in elderly women who are unfit for surgery, who can't
Unfit for surgery.
undergo who can't undergo vaginal hysterectomy, ma'am. Then other than that, during pregnancy, it can be used
Yes.
to support the prolapsed uterus until delivery. Then women who are desiring for future fertility, for them it can be used, ma'am.
Yeah. So mainly
Usually, the ones where
yeah. So as you told, during pregnancy, that too in the first trimester only. Okay, once it is second trimester, uterus will become abdominal organ. It is not needed. And immediate post-delivery. Okay, postpartum period that is required. And elderly who is not fit for surgery. And those who want desirous of future fertility, ring pessary is not an option. Okay, you have various other treatment procedures, right? So they are surgeries, or what we call it as a fertility sparing surgeries for uterovaginal prolapse or sling surgeries. Have you heard of sling surgeries?
yes,
Okay. So to keep the uterus in a normal, try to keep the uterus in a normal anatomical position. Okay, with the use of mesh or the tape, muslin tape. So we are going to give a conservative treatment for that. Okay. Pessary, only very few indications, because what is the problem with the pessary? It needs to be changed, right? Every 3 months you need to change. And if it is very tightly fitting, it can lead to erosion, it can lead to infection, ulceration, right? Yeah.
yes.
You see, if it is the patient doesn't come to you for follow-up, so it can, the pessary can be there for years, and it later on it can lead to erosion, fistula.
And all that, ma'am.
Yeah. So that's why pessary is not a first option for any patient, if you want to tell. Okay. But only few conditions where we can use this. And suppose the patient had a decubitus ulcer. We are talking about decubitus ulcer. Can you tell about the decubitus ulcer, how it is formed and what is the treatment for this?
Ma'am, usually when there's prolapse and due to due to exposure of prolapse, of the uterus, this decubitus ulcer is formed. It's a pressure ulcer, ma'am. Usually,
Yeah, it's a pressure ulcer, definitely, because of the stasis, right? So, and it is a chronically exposed to the outside irritation and all. So, there can be keratinization and desquamation, secondary infection can lead to ulceration. Okay,
yes.
and congestion, venous congestion also. So, the treatment is mainly to reduce the prolapse so that the ulcer will heal. Okay. In such cases also you can go for a pessary so to keep the uterus temporarily reduced. It's a temporary treatment, right? Okay. So we were talking about the sling surgeries. Do you have any idea, like any surgery names or conservative surgery? Suppose if there is a congenital elongation of the cervix, what is the
Yes.
procedure which is done?
The most commonly used is
Yeah. Yes, you can tell.
mid-urethral slings are most commonly used, ma'am.
Yeah, see, midurethral slings are for stress urinary incontinence. Okay.
Yes.
Midurethral sling is for stress urinary incontinence. For a prolapse where there is a cervical elongation, it is a Fothergill's. Have you heard of Fothergill's operation?
Yes.
Okay. Fothergill's operation is one of the conservative surgeries. What are the, can you tell the steps? Do you have any idea about the surgery, Fothergill's? Yeah, I think somebody has answered here. It's Sachin Gupta. So if you want to answer, you can unmute and tell what are the steps, just a basic steps in the Fothergill's, what is done.
Ma'am, it's contraindicated in severe procedentia. Then also contraindicated in postmenopausal women. The steps include cervical amputation, the first step, which removes the elongated cervix. Then the second step would be plication of cardinal plus uterosacral ligaments. And the third step would be anterior repair. Basically, the anterior or
Yeah. So mainly the cervical amputation will be done in this, right? Preliminary before the DNC can also be done so as to avoid any collection within the endometrium. Okay. And Meccan rods are plicated anteriorly and the redundant vaginal wall is also stormed off suture vital. So to cover the raw area, the vaginal flaps are covered. Okay. So what is the problem with this procedure?
there can be cervical stenosis, which is most common, ma'am.
Yeah.
Then recurrence of prolapse can occur. Then there can be menstrual abnormalities. One complication would be dyspareunia.
Yeah, suppose she becomes pregnant, you have amputated a cervix. So if the cervix is left when the cervix is very short, incompetence can also be there, right? Cervical incompetency, which can lead to recurrent pregnancy losses. And also if there is a cervical fibrosis, because you have amputated the cervix, it can undergo fibrosis. So cervical during labor, there can be cervical dystocia also. Okay. So, and as you told, cervical stenosis. Okay. So there is a modification for this Fothergill's, where the step of cervical amputation was excluded. That is called as modified Fothergill's, or what is it called? Manchester's. Okay. So where amputation was not done, but the plication of the ligaments anteriorly was done so as to prevent the prolapse. Okay. And the sling, coming to the sling surgeries, there are Purandare, Kana, like that. So the basically here they use the marceline tape or the mesh to anchor this uterus. Okay. to the ligaments, especially the posteriorly to the sacrum, middle sacral ligament, that is called as hystropexy. Okay, or anteriorly to the anterior superior. In Purandaris, what is done is here the either you can take from the body itself, autograft, that is the rectus sheath. Okay, so rectus sheath is itself is more taken as a sling, and the cervix is anchored. Okay,
Yes.
yeah, so that is also can be done. Sling surgeries are usually preferred for a young patients.
Yes, ma'am.
Okay, otherwise, who has completed family and all, the definitive treatment will be, yes, definitely it is vaginal hysterectomy with pelvic floor repair, anterior colpopelvic, posterior colpoperineophy. So coming to the surgery, can you just briefly tell me the intraoperative or the postoperative complications with vaginal hysterectomy with pelvic floor repair? How many minutes more we have? Yes. I couldn't hear you. Do we have 5 to 10 minutes?
Yes, ma'am. Please conclude in 10 minutes because we have other
Yeah,
assignment.
sure. Yeah, okay. Thank you.
Thank you.
Yes. So can you tell about the intraoperative complications while doing a vaginal hysterectomy with pelvic floor repair? What are the complications you can have?
Ma'am, in intraoperative, the most common would be on the cervix. Then there can be bladder injury. Risk is higher if there was any previous surgery. Other than that, there can be injury to the uterus, ma'am. Then there can also be rectal injury. And there can
Bleeding,
also be
okay?
suture-related injury, ma'am.
Yeah, okay. So coming to the postoperative period.
Post-operative complications include infection, ma'am. That is the most common. Then there can be urinary problems. Recurrence
Yes.
of prolapse can happen, ma'am. Then there can be bowel dysfunction and dyspareunia.
Yeah. Again, in the post-operative period, there can be hemorrhage. Okay. So there can be slippage of ligature or the collection of the blood. Secondary to infection, there can be hematoma formation also can be there. Okay. And also your urinary symptoms, retention can be there or UTI can be there in the post-operative, immediate post-operative period, all this you can come across. As a late complication of this vaginal prolapse, what can be the delayed complication you can anticipate in this patient? And you can prevent it by taking extra measure while you are doing a surgery for the prolapse.
Ma'am, late complications include recurrence of prolapse again.
What do we call that as? What do you call that as? You have done already a hysterectomy, and so again there is a prolapse. What is it called as?
It's usually due to weak pelvic floor, ma'am.
What is it called? Vault prolapse, right? So it
Yes.
is a vault prolapse. Okay.
Yes.
So vault prolapse. So you can, when you're by taking an extra step, right? You are suspending the vaginal angles to the uterosacrals, or by taking a by doing McCall's caldoplasty. So you are going to prevent the vault prolapse. Okay.
Yes.
That has to be done when you are doing a primary repair, that is your vaginal hysterectomy with pelvic floor repair. Okay. And especially when you are, what is procedentia?
That is the fourth stage of prolapse, ma'am, where the
Yeah. So
entire
complete immersion.
amount of the
Right.
vagina.
Yeah. Complete immersion of the vaginal walls and the complete uterus is outside. So when you are doing a vaginal hysterectomy with pelvic floor repair for procedentia case. Okay. So here your vault will be even at a lower level only. So what you can do a sacrospinous fixation or associated colpopexy, so as to prevent the vault prolapse in the future. Okay, that is one extra step we should have to take to prevent vault prolapse in the future. Okay, yes. And detail about the surgery and all will not discuss with you people. If you have any doubts related to this prolapse case, you can ask. Anything you want to discuss about the prolapse or
Hello, guys. If you have anything to ask the ma'am, please unmute yourself and you can speak up.
It was nice presentation. Such presentation should continue in coming days. Madam, thank you very much. I felt
Thank
as
you,
if
sir.
I was in a medical college in UG period. So thank you so much, madam. The way you
Thank you, sir.
taken this forward was very nice. And thank you so much on behalf of IMA Karnataka State Branch. Thank you so much. Thanks.
Thank you, sir. Thank you for giving this opportunity.
And
Thank you.
thank you, Sana, for presenting. Thank you so much.
Thank you, sir.
I think there are no more questions, ma'am. Follow me.
Yeah, sure.
Okay, so
Just a second. Just a second. A quick update to the participants. A quick update to the participants. Since there is some issue with the chart, we couldn't upload the link for the certificates. It will be shared in the WhatsApp group. Just fill the attendance code OBG case 2026. So the link will be shared there. You can fill the form and the certificates will be sent to your email address. Thank you.
Srinidhi, just forward it to me in WhatsApp. I'll share here.
Sure, sir. I am sending.
Yeah,
But the participant cannot fill the form. No, the chat is not opening.
You just share it to me. I'll share.
Sure, sir. Sure.
Okay, Srinidhi and Aditi, the whole thing is well. I think Madam should be here. I thank our moderator. I think Madam has left. Bhavya, ma'am.
No, sir, I'm there here.
Thank you for a
Thank you, sir.
excellent moderation, ma'am. And I also, thank our presenter Sara Purushottam, who has presented this case well, and all the participants who attended this very much patiently, and the whole sequence of the presentation and moderation went on fantastically. It was like, you were again, as same word I have to echo how Veer Bhadraya sir said, that you were attending a class by your own self. It was an excellent rememorization of your memories of your MBBS days. It was an excellent thing which has happened, and I request the whole team to have such programs more and more in our coming days. Thank you very much, ma'am.
Thank you, sir. Thank you so
Thank
much.
you, ma'am. Thank you.
yes. Thank you, Sarah, for that informative and well-presented case discussion. And thank you so much, ma'am, for your valuable insight and guidance. Your comments have undoubtedly enriched today's learning experience. We have now come to the concluding part of today's program. I invite Malvika to do the vote of thanks.
Good evening, everyone. As we conclude today's session, I would like to extend my heartfelt thanks to our presenter, Ms. Sara Purushottam, final year MBBS student from AJIMS Mangalore, for her excellent presentation on nutrient prolapse from diagnosis to definitive management. Thank you for sharing your knowledge and insights with us, Sarah. I would also like to express my gratitude to our moderator, Dr. Bhavya HU, Professor and Unit Head, Department of OBG, Subbaya Institute of Medical Sciences, Shimoga, for guiding the session and enriching the discussion with her valuable expertise. My respectful thanks to our esteemed office bearers, Dr. Veerbhadraya TA, President IMA KSB, Dr. Suriraju V, Honorary Secretary IMA KSB, Dr. Jaspal Singh Tehalia, Chairman IMA MSN Karnataka, and Dr. Alvin Alva, Coordinator IMA MSN Karnataka, for their continued support and encouragement of these academic activities. I would also like to thank the IMA MSN Karnataka team and the academic subcommittee for organizing this wonderful session. Looking forward to more. Finally, a big thank you to all the attendees for joining us this evening and making the session a success. With that, I conclude the vote of thanks. Thank you and have a pleasant evening.
Thank you, Malvika, for the gracious vote of thanks. With that, we conclude today's case presentation session. On behalf of IMAMSN Karnataka State Branch, I thank all of our dignitaries, speakers, moderators, and participants for joining us. We look forward to seeing you at our future academic events. Have a wonderful evening, stay safe, and keep learning. Thank you.
Thank you.
Thank you. Thank you.
Thank you.